Finals SAQ38 Induced Hypothermia. Introduction. The NICE guidance from 2011 advised cooling to 32 to 34 degrees Celsius for patients who had suffered cardiac arrest followed by return of spontaneous rhythm. Subsequent research has found no improvement in outcome when targeting 33 compared to targeting 36 degrees Celsius, yet hypothermia is associated with significant complications. Temperature control following cardiac arrest is now called targeted temperature management, aiming for 36 degrees Celsius in the hope of gaining the benefits of temperature control and avoiding pyrexia, which is common following resuscitation from cardiac arrest. A. What are the cerebral physiological benefits of induced hypothermia following successful resuscitation from cardiac arrest? Targeted temperature management avoids the deleterious effects of pyrexia. Pyrexia commonly occurs after resuscitation from cardiac arrest. Effects of reducing core temperature to 36 degrees Celsius includes reduced CMRO2 leading to reduced oxygen and glucose consumption, reduced cerebral blood flow and potentially reduction in ICP, reduced release of oxygen-free radicals during reperfusion after cardiac arrest, and also reduced consumption of endogenous antioxidants, reduced destructive neuroexcitotoxic cascade involving glutamate release, receptor activation, intracellular calcium overload and cell death. Reduced expression of pro-apoptotic signals, which includes reduced caspase activity, increased BCL2 expression, and prevention of mitochondrial dysfunction. Reduced cerebral edema associated with reperfusion and reduced interstitial collagen fragmentation. B. How can a patient be cooled in these circumstances? Measures include surface cooling and internal cooling. Examples of surface cooling includes ice packs, surface heat exchange devices, and surface cooling helmet. Examples of internal cooling measures include endovascular cooling devices and infusion of cold fluids. C. What adverse effects may occur due to the use of induced hypothermia? Respiratory effects include increased risk of pneumonia. The oxygen-hemoglobin dissociation curve shifts to the left, leading to increased hemoglobin-oxygen affinity, reduced oxygen release, and reduced oxygen delivery. There is increased catecholamine release leading to pulmonary vasoconstriction, increased PVR, and increased right heart afterload, which may lead to right-to-left shunt or right-sided heart failure. Cardiovascular effects. Catecholamine release leads to increased oxygen demand, increased cardiac output, hypertension, and risk of myocardial infarction. Arrhythmias may reduce cardiac output. Shivering increases oxygen demand. Systemic vasoconstriction leads to increased SVR, reduced delivery of oxygen to distal tissues, lactic acidosis, poor wound healing, and increased risk of pressure sores. Neurological effects include reduced mental function. Shivering increases oxygen consumption, post-op pain, makes monitoring unreliable such as ECG, NIBP, IABP, and SpO2, increased CO2 production, catecholamine release, and cardiac output. Endocrine effects include reduced insulin release with increased insulin resistance leading to increased blood glucose levels. GI effects include reduced motility, compromising enteral nutrition. Pancreatitis may occur. There is reduced hepatic function. Hematological effects include reduced platelet number and function, prolonged bleeding time, risk of increased blood loss, reduced clotting factor function. Increased blood viscosity increases the risk of venous thromboembolism. Immune effects include reduced immune function and overall increased risk of sepsis and infection. Renal effects include diuresis and loss of electrolytes. There is risk of hypovolemia and electrolyte imbalance, which may lead to arrhythmias. Metabolic effects include lactic acidosis, hyperglycemia due to reduced utilization. Metabolic rate reduces 6 to 7% for every 1 degree Celsius drop in core temperature from normal. All enzymatic reactions of intermediate metabolism are reduced. This increases the duration of effects of most drugs due to reduced clearance. Hypokalemia may occur. D. In what other non-surgical clinical scenarios may the use of induced hypothermia be beneficial? Beneficial effects have been shown in animal studies. when induced hypothermia is applied to patients with traumatic brain injury, spinal cord injury, and refractory status epilepticus. However, there are inadequate evidence in human studies. Additional information. Surgical indications for induced hypothermia includes neuroprotection, CABG surgery, surgical repair of thoracoabdominal and intracranial aneurysms, pulmonary thromboendarterectomy, and arterial switch operations in neonates. Adult post-cardiac arrest care algorithm by AHA in 2020 recommended that if patients is not following commands, start targeted temperature management as soon as possible, to begin at 32 to 36 degrees Celsius for 24 hours by using a cooling device with feedback loop. The full algorithm is as follows. There are two phases, the initial stabilization phase, and a second phase involves continued management and additional emergent activities. In the initial stabilization phase, when ROSC is obtained, resuscitation is ongoing during the post-ROSC phase. Many of these activities occur concurrently. Prioritization should follow these steps if necessary. Airway management, ensure early placement of endotracheal tube. Waveform capnography or capnometry to confirm and monitor endotracheal tube placement. Management of respiratory parameters. Titrate FiO2 to achieve SpO2 of 92 to 98%, and titrate minute ventilation to achieve PaCO2 of 35 to 45 mmHg. Manage hemodynamic parameters by administration of crystalloids and/or vasopressor or inotrope to achieve systolic blood pressure of more than 90 mmHg or MAP of more than 65 mmHg. Obtain 12-lead ECG. Consider emergent cardiac intervention if STEMI is present, or when there is unstable cardiogenic shock, or when mechanical circulatory support is required. Early evaluation of 12-lead ECG and consideration on hemodynamics affects the decision on cardiac intervention. If the patient is not following commands, start targeted temperature management as soon as possible. Begin at 32 to 36 degrees Celsius for 24 hours by using cooling device with feedback loop. Obtain brain CT, EEG monitoring, and other critical care management. If the patient is awake, continue other critical care management, which includes continuous monitoring of core temperature, such as by esophageal, rectal, or bladder probe, maintaining normoxia, normocapnia, and euglycemia, provide continuous or intermittent EEG monitoring, lung protective ventilation, etc. Evaluate and treat rapidly reversible etiologies, such as the 5H and 5Ts, hypovolemia, hypoxia, acidosis, hypo or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, thrombosis in the pulmonary or coronary circulation. Involve expert consultation for continued management. Thank you.